Good day everyone. In last video we discussed about preparation, application and after stretching procedures. In this video we will be discussing the stretching procedures according to the anatomical plans. So starting with the upper limb stretching. Now for the upper limb stretching, special considerations have to be considered because scapular stabilization is very important. So because many muscles which involve with the shoulder motion, they are attached to the scapula rather than thorax. So when most of the muscles of the shoulder girdle are stretched, so we have to stabilize the scapula. And without scapular stabilization, the stretch force is transmitted to the muscles that normally stabilize the scapula during the movement of the arm. So these muscles will be possibly overstretched, and sometimes it could disguise the true increase in the range of motion of the glenohumeral joint. So whenever we are giving upper limb stretching, we have to keep in mind that first the scapula has to be stabilized, and the movement like abduction or external rotation, they should be about only at 120 degrees of shoulder flexion and abduction that can occur in the glenohumeral joint. And the humerus, it must be externally rotated to gain the full range of motion of abduction. And muscles which are most apt to become shortened, they will be preventing the shoulder flexion, abduction and external rotation. And these movements like abduction, flexion and external rotation is majorly affected or limited at the shoulder joint, and very rarely there could be restrictions in shoulder adduction and extension. So starting with the flexion of the shoulder, so if you increase you need to increase the flexion of the shoulder, then we have to stretch the shoulder extensors. So the hand placement and procedure will be, we have to grasp the posterior aspect of the distal humerus just above the elbow as shown in the figure, and then we have to stabilize the axillary border of the scapula to stretch the teres major. And if we have to stretch the latissimus dorsi, then we will be stabilizing the lateral aspect of the thorax and the superior aspect of pelvis. And we have to move the patient's arm into full shoulder flexion to elongate the shoulder extensors. So in case to increase the shoulder flexion, we have to stretch the shoulder extensors. So this is the hand placement and stabilization of the scapula. Firstly, to stretch the teres major, and second is to stretch the latissimus dorsi, where the hand position and stabilization of pelvis is also required. Now next is to increase the abduction of the shoulder. So if we need to increase the abduction of the shoulder, we have to stretch the shoulder adductors. So with the elbow flexed to 90 degrees, we have to grasp the distal humerus, stabilize the axillary border of the scapula, and move the patient's arm into full shoulder abduction to lengthen the adductors of the shoulder. So in the picture you can see the hand placement and stabilization of the scapula to increase the shoulder abduction. Next is to increase the hyperextension of the shoulder. So to increase the hyperextension of the shoulder, we have to stretch the shoulder flexors. So patient's position is in the prone position. Support the forearm and grasp the distal humerus. Then stabilize the posterior aspect of the scapula to prevent any trick movement or substitute movements, and move the patient's arm into full hyperextension of the shoulder to elongate the shoulder flexors. So this picture shows the hand placement and stabilization of the scapula to increase extension or hyperextension of the shoulder. Next is the adduction of shoulder. So if we need to increase the adduction, we have to stretch the abductors. So it is rare when patient is unable to adduct the shoulder fully to 0 degree. So the upper arm is at the patient's side. So if a patient has worn an abduction splint, like after any soft injury or joint injury of the shoulder, then he or she is upright. The constant pull of gravity elongates the shoulder abductors, so the patient can adduct to the neutral position. So external rotation of the shoulder. To increase the external rotation, we have to stretch the internal rotators. So abduct the shoulder to a comfortable position. Initially you can take 30 degrees, then progressing to 45 and then to 90 degrees. So if the glenohumeral joint is stable, and place the we have to place the arm at a patient's side if it is not possible or glenohumeral joint is also involved. So flex the elbow to 90 degrees so the forearm can be used as a lever, and grasp the volar or palmar surface of the mid forearm with one hand, and stabilization of scapula is provided by the table on which the patient is lying, and we have to externally rotate the patient's shoulder by moving the patient's forearm closer to the table, and this fully lengthens the internal rotators. So shoulder position is slightly abducted and flexed. Hand placement is at the mid to proximal forearm to increase the external rotation of the shoulder, and a folded towel is placed under the distal humerus to maintain the shoulder in slight flexion. So, and the scapula is stabilized by the table. Now to increase the internal rotation of the shoulder, we have to stretch the external rotators. Abduct the shoulder to a comfortable position, and that allows the internal rotation to occur without the thorax blocking the motion. Like initially start with 45 and eventually to 90 degrees of abduction. And flex the elbow to 90 degrees so the forearm can be used as a lever, and grasp the dorsal surface of the mid forearm with one hand, and stabilize the anterior aspect of the shoulder, and support the elbow with the other forearm and hand. And we move the patient's arm into full internal rotation to lengthen the external rotators of the shoulder. Next is to increase the horizontal abduction of the shoulder. So we to increase the horizontal abduction of the shoulder, we have to stretch the pectoralis muscles. So to reach full horizontal abduction in the supine position, the patient must be at the edge of the table, and we begin with the shoulder in 60 degree to 90 degrees of abduction. Patient's elbow may also be flexed. Now we have to grasp the anterior aspect of the distal humerus, stabilize the anterior aspect of the shoulder, and we move the patient's arm below the edge of the table into full horizontal abduction to stretch the horizontal adductors. So this picture shows the hand placement and stabilization of the anterior aspect of shoulder and chest to increase the horizontal abduction of the shoulder, that is past neutral, to stretch the pectoralis major. Thank you.